Good evening, everybody. I hope you can hear. Okay, you can hear me now. That's good. Just the joys of modern technology. Even though it said I was unmuted, apparently the computer didn't think so. So you're very welcome to this, the latest of our Wednesday evening webinars, which I'm very grateful this evening for our colleagues Jerry McCarthy, who's the National Clinical Lead in Emergency Medicine, and Conor DC, David Menzies, Keith Sinnott, Fergal Hickey, Nuala Quinn, and Cathal O'Donnell, who are going to join us for what is going to be, I suspect, quite a lively debate about the trauma teams and the trauma service. And judging by the number of people who have actually signed up to participate, and we're now at nearly 185 people online, it's going to be of great interest. Indeed, I got an email earlier that there are nearly 400 people who have signed up to listen in. So I'm very grateful to Jerry and our colleagues. Just those of you who were on a few minutes early would have seen the flyer for the charter meeting. We have 120 speakers from 5 continents over 4 days. It really is extraordinary what we've been able to do. And I would urge you all to register and dip in and out as you can. But I would really bring your attention to the 4 lectures. I've heard lecture. I've heard some of the lectures that Colin Pearce. Can you make sure that you're muted? Whoever's just come on there has given an outstanding Millen lecture, and Fintan O'Toole has recorded a really outstanding lecture on public health and public wealth, which I'm sure all of you will want to listen to. And then we've got Vivian McAllister talking about his experiences in Kandahar as a Canadian military surgeon. Then also we've got the Collis lecture, which is going to be given by James Lau from Hong Kong, who really was at the forefront of developing surgical endoscopy for bleeding upper GI lesions. And so those are really 4 very special lectures that I hope you'll dip into. Anyway, I'm going to step back, turn off the mic, and let Jerry take over, and we look forward to a very interesting discussion. Jerry, thank you so much.
Thank you very much, President. Look at Pauline's ahead of me. There she is with the slides. Thank God for that. So that augurs well for the start of it. Thank you very much, and I'm delighted to have such a large audience here for what we would really like to have as a panel discussion. So rather than have 6 people deliver 6 didactic lectures and take up all the time, I have a slide set here that I'm going to talk to about the rationale for why we chose inclusive trauma networks as an approach in Ireland, and pause along the way to invite different members of the panel to speak to their area of interest. We also have some interesting questions that have been submitted beforehand, and we would encourage you to use the chat function for any new questions that occur to you. Pauline, if I could have the next slide, please. President has already introduced the members of the panel, so I won't go through them again. Next slide, please. So I think what has been shown in any developed healthcare system in the world, that the introduction of a trauma system is time and time again, if it's properly introduced, and I think that's the challenge, and Keith may have some words to say on that later, it consistently shows very significant benefit in terms of mortality, morbidity, and effectively pays for itself after a few years. Next slide, please. The inclusive trauma network approach fits in with the general approach for the future model of care for unscheduled care, which, in keeping with slow into care, is to keep as much care as locally as is safely possible. So what we're intending to do with the inclusive trauma network is deal with most of the trauma numerically in injury units and trauma units, and indeed the local emergency hospital, but to search for what I call the needle in the haystack, the small number of seriously ill and injured, accepting that we'll have a degree of over triage, and bringing them to the specialist care centre, which in the context of trauma would be the major trauma centre. Next slide, please. It has been well shown that the key components of a trauma system are, first of all, to try and minimize its occurrence, and there has been great advance in that in recent years. Connor, as chair of the major trauma audit, may want to speak something to that later on, or perhaps not. Pre-hospital care and retrieval must integrate to get the patient as safely and as rapidly to the area that will be able to provide comprehensive care for it. That may or may not include stopping off somewhere along the way if the patient is too unstable, recognizing that they need to go to a major trauma center ultimately, and which one they will be going to. The reception and intervention phase is really the one that is the subject of our talk tonight, which is where the trauma team that initially receives the patient and begins initial interventions, leading on to reconstruction and ongoing care. And the bottom arrow there, and next slide please, shows the importance of early access to acute rehabilitation. That has been shown time and time again. So the components of an inclusive trauma network include a small number of major trauma centers where the greatest number are the patients with the greatest injuries will be brought there as safely and rapidly as possible to receive consultant-led care. All the major specialist services relevant to the care of major trauma will be on that site. And it, as already alluded to, a managed transition to early access to acute rehabilitation where the patient's needs will be assessed within 48 hours of their trauma. The trauma unit, of which there is a much greater number than there are major trauma centres, will provide definitive care for most injured patients and will also take some patients who, if they were injured close to a major trauma centre, would go to the major trauma centre but need to stop off along the way at the trauma unit for resuscitation and stabilisation. The local emergency hospital will effectively be created out of the establishment of inclusive trauma networks because it will be one of the 24/7 emergency department that no longer routinely receives ambulance-borne victims of trauma. And then the injury unit, as we've already mentioned, that's a well-established model of care within the emergency medicine programme. There are 11 of them in Ireland, Smithfield in Dublin and Loughlinstown being good examples. There are 3 of them in Cork County, and they see 100,000 patients in aggregate every year now. Next slide, please. So, in approaching what is the best way to establish inclusive trauma networks in Ireland, it was important to look at where the population base is. There's no great surprise there. We can see the concentration in the eastern region, in the Dublin region. We can see Cork, Limerick and Galway as darker spots there as well. And noticeably on the western seaboard and in parts of Wicklow, there's very sparse trauma. They're a long way away from planned major trauma centres and trauma units, where we certainly know that people fall off cliffs, they have water accidents, all sorts of trauma happens in those places. Next slide, please. So, a very important recommendation within the trauma report was dealing with pre-hospital care by means of enhancing ground, so enhancing how ambulances get there, get you to the place you need to go. And since the trauma network report has been published, the establishment of the role of the critical care paramedic has come along. Conor, I might ask you to say a few words on that. David Menzies was supposed to be on the call as the clinical lead for retrieval medicine, but guess what he's doing? He's doing a retrieval. I think there's so much inter-hospital transfer going on in the current pandemic that it's all hands on deck. Conor, do you have anything to say in your role as National Assistant Medical Director of the National Ambulance Service on the development of the role of critical care paramedic? I think you're on mute, Conor. Conor, you're on mute.
Thanks, Ray. Can you hear me now?
Yeah.
Okay, so I suppose the requirement associated with pre-hospital care is going to change in the proposed trauma networks model, in that paramedics will be required to keep patients alive for longer, if you like, before they get to the major trauma centre or the trauma unit. And that requires an enhanced skill set. So from 2009 to 2012, I worked with Ambulance Victoria in Melbourne, and I worked as a consultant in the Alfred Hospital in Melbourne. And what I witnessed there was mobile intensive care paramedics who would intubate and provide a neuroprotective anaesthetic to head injured patients. They would bring patients in on blood. They would bring patients in on inotropic support. And so that sort of opened my mind to the fact that paramedics with enhanced training, enhanced knowledge, enhanced skills, ongoing CPD were capable of a lot more than what I had witnessed them being what I had witnessed them doing elsewhere. Now, up the road in New South Wales, there was a different model of care in place by Sydney Hems, whereby the Sydney Hems service was providing primary and secondary retrievals. So they would have doctors in helicopters that would pick up a patient and bring them from the roadside, or they would bring them from another smaller hospital into a major trauma center. So there are two models, if you like, in existence around the world: a paramedic-based model and a doctor-based model. In terms of Ireland, we have given license, if you like, or we have validated the need for a critical care paramedic in the Pre-Hospital Emergency Care Council. So FEC have signed off on a model called the critical care paramedic, who would have an enhanced skill set, and this would be a tier of the pre-hospital response. And obviously, we also have MICAS. Unfortunately, David isn't here to speak of it, but there is the potential, I suppose, for it to extend its role into primary retrieval as well. So I'm not sure if that covers the question you asked.
I think it certainly does. Conor, thank you very much. That was very helpful. So Pauline, if we could go back to the slides. We were dealing with enhancing pre-hospital services, and we spoke about enhancing ground transfers, critical care paramedic. Thanks, Conor. That was a very helpful update. There's also mandatory part of inclusive trauma care networks is hospital bypass and no refusal policies. So if the appropriately trained advanced paramedic or critical care paramedic, Pauline, are we getting the slides back? I wonder. Decides with pre-hospital triage that patient should bypass a certain unit, that's automatically accepted within the network. Now, supplementing that is further development of helicopter emergency medical services, because we saw earlier, some of the patients get injured far away from the places they need to go to. And included in the helicopter emergency medical services is rapid transfer of the patient to the hospital, but sometimes we have rapid transfer of the hospital to the patient where someone with certain critical procedural expertise in pre-hospital care is brought to the patient. Again, David would have been speaking to that. If any of the rest of the panel want to say anything about it, that's fine, or I'll just keep moving on. I'll keep moving on, I suspect.
Jerry, somebody is trying to share the slides, and they're knocking my slides out. I'm just trying to get them back up for you there.
Okay.
You just have to hold a moment.
We're being hacked. Does that mean we've arrived?
I think somebody is trying to hack us. Yeah, hold on a moment.
Okay, thanks, Pauline. So, Nuala, I wonder, you've been doing work recently on, if you like, hospital bypass and no refusal policy with children. You're not long back from down under, I think, with a lot of MTC and trauma specialist interest. And since you come back to Ireland, I think you've been developing protocols, particularly for head injured children. Do you want to say anything?
Yes, that's right. So I was in the same part of Australia as Conor. I was in Melbourne. I was there for 4 years in the Royal Children's Hospital, and as part of that 4 years, I worked as a consultant in emergency medicine, and I also did a role as trauma fellow in the kids for a year as well. Now, they have a slightly different system in that their system's exclusive, and just alluding to what Conor said again about the MICAS paramedics. So they had an exclusive system whereby every retrieval would come to the kids' hospital. So a little bit different to what our proposed transfer and transport in our trauma network is going to be. But with that in mind, we identified that there were cases which could have been managed a little bit better, and there were opportunities for us to improve. And one of the groups of patients that could improve in that way were the children with major head trauma. So most of you probably know that Temple Street is the National Neurosurgical Centre for Children in Ireland. And what we wanted to do was to develop a bypass protocol, sort of similar to what the MICAS paramedics would be doing in Melbourne, which would allow those children with major severe head trauma to bypass other institutions when being retrieved by helicopter and come straight to Temple Street to be received by a trauma team there with neurosurgery on standby, and all led by pediatric emergency medicine consultants. So in conjunction with CHI and with the National Paediatric Transport Team and with Keith Sinnott, the lead for trauma, and with other speakers on this panel, we have developed a pathway for the pre-hospital APs undertaking this air bypass. So what we've written is a protocol to facilitate their direct transfer. So basically, Jerry, what that means is getting these kids to the right place at the right time, those time-critical head injured patients to Temple Street. Now, what will happen is that the children who are being retrieved by helicopter or air, these advanced paramedics will be faced with major trauma, and they have criteria that they have to identify in order to activate this aeromedical bypass. So the three criteria are that they identify obvious external head injuries suggestive of skull fractures, which will obviously need neurosurgical intervention. The patients or children who have prolonged reduced conscious level, GCS of less than 12, or if they have that bradycardia or hypertension associated with raised intracranial pressure. So, for example, they identify one of these criteria. They know that these children will need neurosurgical intervention. They're on the side of a road in Nina, wherever. They've gone by helicopter. So rather than go to, say, Limerick or Cork, where they know there's no paediatric neurosurgery, they can do a direct bypass to Temple Street. And as I said, we developed this with the National Ambulance Service, National Transport Medicine Programme of Paediatrics, all key specialties in Temple Street and CHI. And we've also managed to get accompanying education and airway training or advanced airway training for the APs with paediatric anesthesiology. So a really positive step forward, hopefully in the next month or two.
Well done. That's big news. And you're hoping to start in the next month or two, is that what you said?
Yeah, so everything is ready to go. We obviously have national communications that we need to go through, but the processes and procedures and policies are all in place and signed off by all the stakeholders. So just a few loose ends to tie up, and then it's ready to go out to comms to the various hospitals over Ireland.
Great stuff. Well, hopefully that early win, as it may be termed, is a harbinger of other things to come. Would you think, Keith? I see Vida Hamilton has just raised her hand. Is that intentional, Vida?
Yeah, I just thought in the absence of David Menzies, I should probably just mention the fact that, well, they've done 20 adult inter-ICU retrievals in the past 5 days, and he's still doing more, as you mentioned. But given how busy our ICUs were, and of course with the loss of staff due to COVID-related issues, it wasn't possible to use critical care nursing staff in the vast majority of those retrievals. So the critical care paramedics, much like other things that have occurred in the COVID era, it's been a real enabler of change. So the critical care paramedics have stepped up and have delivered on all of those adult retrievals, working with a critical care consultant. And it's been extremely successful. So we're very grateful for them for standing up at such short notice.
That's terrific. We did hope to have Carl O'Donnell, the Medical Director of the National Ambulance Service, with us, but everyone's falling like flies, it would appear. That's great, Vida. Any idea roughly how many critical care paramedics there are?
I've no idea, but they've been able to man the roster fully for the last 2 weeks. Keith may be able to come in here with that.
I see his hand is raised. Keith, you're on mute.
Yeah, just to follow up on what Vida said. I mean, the critical care paramedic role is something that's been discussed for a long time, and like lots of things, it took a while to go through the various loops and things, but COVID provided a great impetus for it. Martin Dunn stood up and said, right, let's go, let's run it now. I think David Menzies got like a 2 or 3 day lead-in time to start the course. I think there was about a dozen and the initial kind of group. I was lucky enough to speak to them, and I think they've already enrolled a second group. So they're up and running. They're providing a great service with the ICU transfers. But I think the other thing is that ultimately they will have a role to play in the pre-hospital space. And I'm sure you're going to talk about that again. But in the notion of networking, the aim is to get high quality care to everybody wherever they are, including those remote areas. There's different models in different countries using pre-hospital physicians. There's people, voluntary organizations like Jason Van de Velde in Cork and David himself in Wicklow. But the critical care paramedics certainly be able to help spread the reach of the pre-hospital services around the country to assist in the networking of the whole system. So it is a great success. One of the few good things, well, a lot of good things that happened with the impetus of COVID kind of driving it forward.
Yeah, I see Keith, Vida, you have your hand electronically raised. I see Connor raising his physically. Thanks. Vida, do you want to come in?
Yeah, just to add. Just to add that thanks to the generosity of Crumlin and the Air Corps, there's also a helicopter on standby to facilitate adult retrievals as well. So a huge amount of support and innovation in a crisis.
That's great. Thank you very much. Connor, are you looking to come in? Can I just ask the backroom team, is someone keeping an eye out for hands up? Because I just can't possibly see 274 participants. But anyway, okay, thanks. Sorry, Connor, yeah, come in.
Just to say, in terms of paramedicine as a craft group in and of itself, okay, so paramedic degree, the National Ambulance Service has started a degree program, so its paramedics will be degree educated, and then the critical care paramedics will be master's educated. So they'll have completed a degree and they'll have done road time, and then they'll come back and they'll do a master's in critical care paramedicine. And there'll be master's programs similarly in community paramedicine, in advanced paramedicine, and various other specialties within the domain of paramedicine. So that's the future. That's what the future holds for paramedicine. So, and it will happen in, trauma is going to be a driver, one of many drivers to support the development of the profession of paramedicine.
Great. Thanks very much, everyone. That is very interesting. I'm going to move on in a moment, but just before I do, I remember when the trauma steering group led by Eilish McGovern was doing its work, and Chris Moran from the UK was an external advisor, and Keith Willett. They fairly much dissed the role of the helicopter in their experience in England, which I think was to do with population densities and that it was faster to get someone there by road. Does anyone have any comment or opinion on the role of helicopter emergency medical services in Ireland? Fergal on the Western Seaboard.
Well, thanks, Jerry. I suppose there's two potential roles. There's primary retrieval, and certainly some of the more isolated areas in the northwest, west, and southwest. There is an argument that if you're, you fall halfway down a mountain, it makes more sense for a helicopter to, with the assistance of the National Ambulance Service, to bring you from there to a place that can deal with all your injuries, rather than you be primarily retrieved to a potential trauma unit and then be transferred from a trauma unit subsequently. So I think there is a role certainly for primary retrieval, and some of that is to do with issues like access and and certainly we've had that experience with people who've fallen off cliffs or people who've cognitive difficulty in water-associated injuries. The role of secondary retrieval, in other words, where somebody goes from a particular hospital to a higher level of care in another hospital, is probably a bit more challenging. And some of the issue around this is things like facilities, the absence of appropriate helipads. That's a rate limiting step, and we know that as a result of the unfortunate search and rescue collision with Blackrock Island a couple of years ago, that there's been a condemnation of many of the helipads around the country, and some of those are currently being upgraded. But also, obviously, the hospital at the receiving end, in this case, we're talking about a major trauma centre, will obviously need the appropriate helipad facility. So I think there is a role. How much of a role it is remains to be seen.
Okay, thanks, Fergal. Now, given that I asked the question and I see Vida and Keith with their hands up in that order, I better let them in, and then we better actually get the patient to the hospital, because we're still in the pre-hospital arena. Vida, you want to come in?
Yeah, I just want to support a lot of what Fergal said. I trained in critical care in Adelaide, and we ran the largest retrieval service, air retrieval service in Australia. So a fair amount of experience with primary and secondary retrieval. And it is very much dependent on the offload and onload facilities. But I do think that if they are gotten right, certainly to support rural areas, there are tremendous benefits in terms of speed.
Thanks, Vida. I see Keith, and then I see Kevin Clarkson. Keith, you're on mute, Keith.
Yeah, sorry, Jerry. Just to make to reiterate what Fergal said, the difference between primary and secondary transfer, there is often an assumption, particularly in the lay press and often in truth with politicians, that helicopters are better than everything else, and it's not always the case. When I started in the matter with the spinal service, all the spinal cord injuries were transferred by helicopter, and it used to take about 2 or 3 days for them to get to the matter when compared to a 2.5-hour road trip. Road transport is safer and quicker if you're on a direct road. So secondary transfers are usually better. The question is primary transfers. And again, what Fergal said, if you're retrieving somebody by helicopter to transfer them to somewhere from where they will need a second transfer doesn't make any sense. So it's not quite as straightforward as helicopters must be really good. There are pros and cons for them. And certainly for addressing the black spots, and you mentioned them, and there are a few around the country, helicopter transfer can be useful. And it's actually, it's an interesting exercise to compare the cost of a helicopter versus the cost of providing some local care in local hospitals. It can be quite instructive, actually. So, yeah, helicopters are really interesting, but you just need to step back a small little bit because they look so sexy. You assume that the answer to everything, but they aren't always.
That's great. Thanks, Keith. Kevin, do you want to come in there? You're on mute, Kevin. Kevin Clarkson. I'm going to have to move on. If you're on mute, Kevin, I don't know, can someone unmute you? We'll move on and come back to you, Kevin, I think. Is that fair?
Sorry, I was on mute there.
Right. Yeah.
Yeah, no, perhaps Fergal is being diplomatic there. I certainly have seen in this part of the world some abuse of inter-hospital transfers, and I'm sometimes surprised at how easy it is just to order it up and hey presto, along they come.
Yes, we would agree with you there. Yeah. Hairdryer syncope has now been taken off the list. But I do think, and Connor, you may want to come in here, things have tightened up an awful lot in recent years for how to activate a helicopter.
Yeah, we don't activate them for secondary transfers that often from Cork. It's easier to put the patient into an ambulance and bring them straight up because of the transfer time from Baldonnel or the Phoenix Park to the subsequent hospital. So it's rare that we would use a helicopter for secondary transport in Cork or secondary transfer.
Yeah, I think the last couple of bullet points on that slide should, proper coordination with advice from an advanced paramedic with additional training in the National Emergency Operating Centre and support from a consultant with significant pre-hospital trauma experience would probably make the calling of helicopters more appropriate. Can we have the next slide, please, Pauline? So if you remember what I've been doing so far is I've given the rationale and justification for the rollout of inclusive care trauma networks. We've looked at the population spread, we've looked at the need to enhance pre-hospital capability, and we've looked at the fact that the component units of an inclusive trauma network are the major trauma centre, the trauma unit feeding into the major trauma centre as necessary, but doing an awful lot of the work, the local emergency hospital, and the injury unit for the ambulatory patient who triages themselves to there. So really the principles of establishment in a major trauma centre is that it would, within its network, provide leadership in trauma organisation and management, and these are straight lifts from the trauma steering report. Consultant-led trauma care with relevant training and competence assessment, and I think that's more important than the actual specialty that the consultant comes from. And on the next slide, I may ask input from some of my colleagues about the specialism versus the competence in trauma assessment and management. Immediate access to operating theatres, CT, MRI, and interventional radiology. I presume you've all that sorted already, Keith, yeah? But I think that's one of the things I've always been concerned in the development of trauma networks, that if you're going to bypass a unit that has a vacant operating theatre and a surgeon, you need to be absolutely sure that the unit you're bringing them to has whatever that patient needs for hemorrhage control and various other things. A dedicated trauma ward, which is a trauma service that really we don't really have in Ireland at the moment. I know a lot of the returnees from down under recently are great fans, but I see Fran O'Keefe on the call, and I know he's very experienced in that. But this would be where the responsibility for the care of the trauma patient is transferred to a single consultant who takes over the coordination of the in-hospital phase of the care, unless it is a single specialty trauma that another specialty is happy to receive. And again, those consultants can come from a number of specialties. And then definitive care and rehabilitation. If we can have the next slide, please.
Jerry, just on that,
yeah,
if I can get in. I suppose that's the comfort really in how this trauma network can be developed and implemented. The comfort is that a trauma service will manage that multidisciplinary aspect, that negotiation, to ensure that the patient gets into theatre at the same time as the plastic surgeon is available with the orthopedic surgeon for that tib-fib compound, high Gustillo grade fracture, or similarly that you have somebody coordinating the rehabilitation needs from early on with the neurosurgeon, with the orthopedic surgeon. So the left hand is talking to the right hand, and things are happening in parallel rather than in sequence.
Yeah, that's great. Thanks, Conor. And this is the second slide about the principles of establishment of a major trauma centre. And a core recommendation, which really would be a huge step in Ireland, is 24/7 consultant availability on site to act as trauma team leader. I will be asking panel's opinions on that in a few minutes. An appropriately trained trauma team present 24/7. So that trauma team is led by a consultant with appropriate expertise who is immediately available on site. That is the end point that we want to reach. Essential within that, even though it's not often needed, but when it's needed, it's kind of needed now, so that the skill set to perform resuscitative thoracotomy would be within the trauma team amongst many other bedside skills. The ability to understand the need for, activate and apply a massive hemorrhage protocol and to know how to do it. 24/7 immediate availability of fully staffed operating theatres, and then ready access to interventional radiology. We've already referred to hybrid suites and that earlier. Does any of the panel want to come in about the specialisms or trauma training, or will I move on?
I suppose it's just important for people to sort of appreciate that there's the initial trauma and reception consultant-led team, and then that patient is, has life-saving thoracotomy done, or has chest drains inserted, intubated, brought in for CT pan scan, decision making around interventional radiology or straight to theatre happens at that point. But then the patient is admitted under the trauma service, and that trauma service coordinates the different specialties within the trauma centre to deliver the optimum care to that patient. So the trauma reception is separate, if you like, from the ongoing trauma care.
Thanks, Conor, after the initial resuscitation. Keith, I have a thing saying your hand is up, is it? I can't see on my screen.
Yeah, sorry, Jerry, just to again, from what Conor said, I think the notion, and I know it's the topic of the entire talk of the team, is really important. It's unusual to have a single injury in major trauma and to have somebody who has the vision of coordinating a team. And that stands for, again, trying to educate myself. I did the European trauma course, which is designed at teaching you to be a trauma team leader. And it was instructive because what a trauma team leader does was stood back and try to coordinate the different skills going on. And likewise, as Conor says, one of the things about a trauma centre hopefully will be the notion of an inpatient trauma team. In the US, you've got kind of trauma clinicians who do surgery and run ICUs and are managing the physiology of the trauma team. I think in our setting, that will probably still be done by intensivists, but to have somebody who can coordinate the different aspects of care is really important. And the entire thing about trauma is it really is a team game. You need to all work together, and that has to be the overriding ethos more than anything else. And there are different levels of teams, and we might speak about that. I know your kind of slides will touch it a little bit more, Jerry, but again, at every level, working together, coordinating people who, because of the nature of specialization, of slightly different focuses, is of critical importance.
Thanks, Keith. And I think you've just given me the segue and reminded me that this session on trauma teams, the EMT webinar, is intended to be complementary and preceding the session to be delivered by the Irish Association for Emergency Medicine on Charter Day on human factors in the resuscitation room in general. So this is specifically about trauma teams in the resuscitation room and the challenges within that. The session on Charter Day is about human factor issues that occur in the resuscitation room, which really occur in trauma and occur in non-trauma patients requiring resuscitation. So if we can have the next slide, please. Just to mention trauma units, the principles of existence, raison d'etre for trauma unit is that patients with injuries within the expertise of the trauma unit would be brought there preferentially. However, we also know, based on the geography that we've seen earlier, patients with injuries that are considered time critical, where direct transfer to the major trauma center is considered unsafe or not feasible because of lack of access to rapid road or air transport or whatever, that they would be brought to the trauma unit in the first instance. So that's quite a challenge for the trauma unit in terms of stepping up to the resuscitative needs of the patient, where they're not set up in exactly the same way as the major trauma center for that. Relevant specialties in trauma units to have early access to them include emergency medicine, anesthesia, and emergency surgery in general. I'm kind of deliberately being vague on which specialties we're talking about there, but someone who can do emergency surgery. If anyone wants to pick up on that, they're welcome to on the panel. But the people on the trauma team would require additional training and expertise in acute trauma, acute modern trauma management, if you like. Can I have the next slide, please? So in trauma units now, this is the greater number of units around the country rather than the smaller number of major trauma centers. There would be required, or so it says in the trauma report, and again, these are challenges that will be coming your way, Keith, I think, 24/7 on-site presence of members, now not consultants, but members of each of the specialties of emergency medicine, orthopedics, general surgery, and anesthesia. Prescribed response times for the specialties that may or may not be needed. So they're, depending on the particular patient in front of you, what the required response time is. And point 3 is probably a repetition of point 1, really, which is that you'd have senior trainees or senior clinicians, not necessarily trainees, in all relevant specialties rather than 24/7, and their consultants available for physical attendance within 30 minutes. As I say, these are lifted straight from the trauma report. They may have developed a little bit since then. Keith, if you have anything you want to say, I'll take the next slide, please. Keith, do you have any comments on that? You're on mute. No, you have no comment?
Well, I mean, only to say that you're absolutely right. A lot of what's in the trauma report is aspirational, and implementing the report is going to be iterative, and it will be step by step on the way to get there. There's obviously a huge amount of things to factor in about providing these rosters and making sure we have enough people, making sure that they comply with this, industrial relations and contractual issues, etc. But yeah, the report, it does lay out where we would like to get to, but clearly it's going to take some time to get there. It's taken time to get to this point, so you can only but imagine it'll take time to go beyond that. So these are the ultimate goals, but we will take a while and have a pragmatic approach towards getting there.
Okay, thank you. I'm actually going to, so we got about 10 questions in before the start of so I'm going to take 2 of them now and offer them to the panel for comment. They probably are linked in that the first one is, do you see a role in the coming years for designated trauma surgeons similar to the USA and Canada? And what pathways do you envisage for the management of exsanguinating hemorrhage?
So Jerry, maybe I might come in here, and I'm sorry, and cut me off. You can hit the mute button if I'm talking too much.
Okay,
but this is obviously a very interesting topic, and it's one of the big challenges about exactly what we're doing. We had a very good meeting kind of before COVID hit, and in fact, one of the international speakers nearly got stranded in Ireland because of COVID, about the role of the emergency surgery, the resuscitative surgeon. And in fact, it was quite useful. There's a very good document from the UK looking at it. And it divides the role of the surgeon in 2. It says surgeons can either be trauma team leaders, or they can be resuscitative surgeons with training in addressing life-threatening hemorrhage. And there's a variety of ways to train in doing that. And a lot of it is kind of out with my knowledge, because exactly how surgeons, abdominal and thoracic surgeons, train at the moment. It's not something I'm an expert in, but I've done the definitive trauma skills course myself, and its main utility for me was showing me how difficult it was, and that it wasn't just something anyone could dip their hand into, but it is a way for experienced surgeons to get the specific skill sets for dealing with exsanguinating hemorrhage. There are also the opportunities for training in trauma-specific fellowships, and one of the things that one of the many challenges that are different between Ireland and lots of the places that we're trying to ape, specifically the UK and the US, is we haven't had any good wars recently, so we don't have a load of trauma surgeons who've been in places with people getting bits blown off them all the time. So experience at that level will really require dedicated trauma fellowships. The UK have now got their trauma systems set up so that there are trauma fellowships, and it is possible that people could go and train there and spend periods of time. There's these kind of TRIG integrated fellowships which allow people to do it. But in truth, I think it would be important for us to have something for people to train towards. And that's one of the benefits of having a coordinated trauma system, in that it gives a career path for people who may have a specific interest in trauma. It's a bit difficult to persuade a surgeon to go and train in dealing with exsanguinating hemorrhage when he's likely to only see it very occasionally in a place where the concentration of these injuries is such that they don't see it very often. So again, all these things kind of come together, and simultaneously there's some discussions in the college about the role of emergency surgeons as opposed to trauma surgeons, so dealing with emergency laparotomies, etc. I know Ken Neely and Debbie McNamara and Ronan have all been looking at this, and there's a short life working group looking at it. So those two developments will happen in parallel to try to provide skill sets to allow people to deal with these infrequent but important, because they're kind of life-saving interventions that they come up with.
Okay, great. Thanks, Connor. I know you're looking to come in,
sorry.
and I'll take you, Connor, if I can just for 1 second. There's a couple of questions have just come in. One is a comment from Bob B, who's giving us the paper that you're referring to on resuscitated surgeons and training, which is useful. The other question from Mick Malloy is already in our list of questions, so we'll come back to it then. Sorry, Connor, I'm trying to keep.
Yeah, just to say, and it's not in conflict with anything that Keith is saying at all, but in the model at the Alfred where I was, you had a blended trauma service. You had a blended group of consultants who formed the scaffold that was the trauma service, and they comprised some trauma surgeons, but also some trauma physicians. And as I said, they were the people who were responsible for the coordination of care of that patient. Now, of a night, the general surgeon or the trauma surgeon who would be responsible for stopping bleeding may not be of that service, may not be of that group of people. It would be the general surgeon who was on call for the Alfred, who had done extra training because he knew he was going to get a decent amount of trauma because he was on call to a major trauma center. But it wouldn't necessarily have been a member of the trauma service. It was the person who was on, so you'd use the vascular surgeon who's on call for the Alfred, you'd use the general surgeon who's on call for the Alfred, or you'd use the, they didn't necessarily, they weren't necessarily part of the service.
And Connor, would it always be somebody who worked in the Alfred, or would it ever be somebody who worked in another hospital?
The nature of the contracts in Australia was you rarely worked in only just one place. You often had affiliations with a number of different hospitals, public and private.
Okay, thanks very much. I might, Fergal, in a couple of slides' time, I'm going to be asking you about the trauma team paper. I just returned to the talk now. That slide there, its main purpose is to show the black line in the middle, which is a changeable line, I think, roughly defining that 1/3 of the patients below the line would be received by the Southern Trauma Network into Cork University Hospital, and 2/3 would be part of the Central Trauma Network. The line is kind of freestyle, I think. Is there someone not on mute? That I hope it's not me. There's a lot of background noise coming here. The hospitals that are highlighted there are, most of you will realize, they're the ones that have trauma and orthopedics on site. So that's been kind of regarded as the hook to make somebody eligible for consideration as a trauma unit. But clearly, just because trauma and orthopedics is on site doesn't mean automatically you'll be a trauma unit. I'm going to move on unless someone like Keith wants to say anything at this stage. No? Okay, next slide, please. So we're moving in now. We've looked at the component units of the inclusive trauma network. We've looked at the type of networks that are coming down the line for Ireland. We already had a brief discussion about pediatrics because the third major trauma centre will be the Children's Hospital. Nuala, I might come back to you in a minute to ask you if you want to make any comment on the state of pediatric trauma network development. If not, I'm happy to do so myself, or Keith even. But we've looked at the trauma networks, we've looked at component units, we've looked at the principles of what's required to be in a major trauma centre and a trauma unit. Now we're getting into kind of the nitty gritty of the members of the trauma team. And Fergal, I'm going to be asking you to come in now in a moment. But trauma teams, be they in a trauma unit or a major trauma centre, need to be led by a consultant. The consultant doesn't need to be physically there, but they need to be aware that this trauma call has gone on and be thinking of coming to attend in a timely fashion. Next slide, please. Within a major trauma centre, an essential requirement that I'm not sure has changed is that there be a CT scanner physically in the emergency department. Increasingly, that is the case in any new builds. An adjacent hybrid suite where interventional radiology could be applied for hemorrhage control, or a body cavity could be accessed if that failed and there was an urgent need. And we've already spoken about immediate access to theatre and ICU for patients who need it but can wait to get to the theatre. Next slide, please. Those component units of CT scanner and ED and hybrid, obviously, they're not requirements of a trauma unit, but the closer your CT scanner is to the emergency department and the closer your operating theatre is and your ITU, I think it's been shown the better the trauma patient does in the longer term. That slide there is just to look at the various members of a trauma team. And Fergal, you're president of the Irish Association for Emergency Medicine. For many years now, you've been chair of the ATLS committee. You're also a very experienced team leader in a trauma unit in Sligo for many years now. Do you want to speak to the position paper from IAM on trauma teams? And we might take the next slide, please, just as an aid memoir.
Okay, so thanks, Jerry. I suppose the challenge was that the most recent major trauma audit report suggested that the number of patients with major trauma who were received by a trauma team was far below what was acceptable. And particularly when you look at elderly patients, they're even less likely to be met by a trauma team. But the difficulty we have in Ireland is nobody's ever defined a trauma team. And the likelihood is that more people were actually received by a trauma team, but it was not named as such, than actually the returns would suggest. So on the back of that, the Irish Association for Emergency Medicine felt that as essentially the specialty that's going to be the majority of the reception and intervention, certainly in the early stages of trauma, that we should define this. And the group led by Shane Broderick, but with Fran O'Keefe, who's been mentioned, Kiva Fitzsimons, who was a nurse contributor, drafted a document which then Jerry, Conor Deasy and I edited and made suggestions on. And what it does is it lays out a tiered response to trauma, be this in the major trauma centre or in a trauma unit. In other words, that there will be certain patients that can be managed exclusively within the emergency department, particularly in a trauma unit. But there's others that will require the involvement of the hospital. So that document is complete. It's supposed to be on the IEM website, but unfortunately our administrator has been off. But what we will do is anybody who wants a copy of it, if they get on to Pauline or Mary Flynn, I've given them a copy of the document which we will share with them. But essentially what the document describes is a tiered response where you have different levels of intervention depending on the likelihood of more and more complex trauma. There are activation criteria for it. There's a definition of who should be on the team. There's definition for, if you like, the ancillary players that are often forgotten, such as radiographers, porters, healthcare assistants. I mean, we often think of doctors and nurses, but there's other people who contribute to this. And I suppose the intention is that we produce the best possible response with the minimal disruption of the whole hospital to achieve the ends that we need to achieve. So that document is available. It's a discussion document really, but it reflects emergency medicine's view of how this should be rolled out, and that when we are talking about a trauma team and whether a trauma team attended, that these are the definitions that we think we should use.
Okay, thanks, Fergal. Can I have the next slide now, please? Which I'm just going to let sit there for a minute, because it's the final slide, apart from a sum up one. We've touched on some of these issues before, but obviously it's really, really important that if people are being asked to take on roles such as this, that there is education and training available. So I'm going to come back in a minute to some of the panel members for comment on that. There are two things I want to do before we finish. I know it's 10 to 7 now, it's 7 to 7. Nuala, do you want to make any high-level passing comment about pediatric trauma network and the state of it? Because all along the adult trauma steering, the trauma steering group was very much geared towards adults in the expectation that we'd have a children's hospital by now.
Yeah, Jerry, that's true.
Yeah.
That, you know, Children's Hospital, hopefully we're looking at 2023. And I mean, COVID has affected everything that all of us have done. But last year, I mean, as you know, so we're now in the process of fully integrating into the adult trauma system. And this was agreed last year among other required actions at a meeting that we had with Keith Sinnott and the CEO of CHI, Eilish Hardiman, and some other members of the panel here as well. So the idea was that we will follow the hub and spoke model, but with one major trauma centre, as you say. We are currently in the infancy in the short-term immediate actions of the phased approach to implementation. So we have, you know, we need to appoint a clinical lead, we need to work on bypass protocols, we haven't done a gap analysis, costings, like all that sort of stuff. And then the fact that, unlike the adult trauma system, we'll only have one major trauma centre means that the focus will really be on developing the trauma units for paediatrics in specific. And so this is where, I suppose, the optimum provision of timely and appropriate care for peds will really come into play. One of the key considerations, or maybe, you know, the key consideration here, and probably the rate limiting factor as well, will be the ability of the trauma units to meet workforce requirements for largely pediatric anesthesia, but other specialties such as gen surgery. And I suppose with this in mind, over the next couple of years, we'll really need to start looking at maybe further bypass protocols, such as the head trauma bypass that we're currently working on, as I said, which is ready for implementation in the next few months. So I'm not sure if that's as highbrow as you'd hope for, but that's
great. Thanks, Nuala. Thank you very much. I said there were two things I wanted to come to, and the last one is I see someone has put up a question, what about neurosurgery? We did receive two questions about neurosurgery, which are more specific really to the major trauma centre rather than trauma teams in MTCs and trauma units as part of the trauma network. But I'll ask the questions anyway and see if anyone in the panel has any opinion. They are, what does the panel think is the role of neurosurgery and neurointensive care in the management of trauma patients and its implications on the site designated for the major trauma centre? The next question, there's a statement at the start of it that the country needs and deserves a trauma system that deals with all serious head trauma cases. I think that's a given. And then that's a complete neurosurgical service. And does the panel, so here's the question really, does the panel agree that the entire Beaumont Neurosurgery Department, with its supporting disciplines, detailed, should be located on, sorry, this has run out, but I think it's on the one site, best practice, rather than a two-site model that is one small unit for head trauma and the other larger unit for hemorrhage, tumours, etc., which is not regarded as best practice. Anyone have any comment?
Jerry, it's Keith here.
Thanks, Keith. Yeah.
So, as you know, as I alluded to before, Ireland is not like everywhere else in lots of different ways. And one of the things that we don't have in Dublin is we don't have a 1,000-bedded hospital with every specialty on site. And that's the reason why designating a trauma centre for the Dublin region has been difficult. I am absolutely delighted that I was not the person who had to decide where the major trauma centre was going to be. It was made very clear to me when I was appointed that I had nothing to do with it. In fact, I was appointed afterwards. And I'm not sure if you want to discuss that at all, Jerry. What I can say about it is that the designation process itself was very laborious. Most people who would share what everybody has said, which is that we should have a trauma system, are frustrated by how long it's taken. But when difficult decisions need to be made, it can take some time to take them. As you know, there was an independent assessment panel which reviewed the totality of trauma care. And as I've said repeatedly, and I will say till my dying day, trauma care is a team game. And despite the fact that I'm a spine surgeon, we typically have massive egos. I do realize that we've only got a small role to play in that team, and the important thing is the coordination of it. The independent assessment panel have made a report regarding the designation. It was studied for a prolonged period of time by the executive management team in the HSE and also by the board of the HSE, and they've submitted a recommendation to the minister. As Nuala said, COVID obviously messed things around. And it's one of many things that mess things around because, as you know, as you may be aware, the letter went to the minister at the time of the election. Then it took us 3 months to form a government. Then we had a minister for health who was dealing with COVID. Then we had the lull after the first wave. Now we've had the catastrophe of the third wave. So we're getting to the point where the designation will hopefully be affirmed by the minister. At that point, the real benefit of teamwork comes in. And I have absolutely no doubt that when the difficult decision is made, everybody who's got an interest in trauma will work to make the best possible solution. As I said before, and as was made very clear by Chris Moran when he came to visit, you might think it's nice to build an enormous big hospital in Athlone that can deal with everything. That will never, ever happen. So that's as much as I can say about that. Neurosurgery will be part of the trauma centre because how could it not be? As will all the other specialties that are involved in dealing with major trauma, and specifically the specialties who will coordinate managing all the aspects of the patient's care. It is not beyond the wit of man to make it work. We are a small country. We're all friends. We all get on well together, and we will be able to make it work so long as we remain focused on the guiding principle, which is right patient, right place, right time. We have to get the right patient there. We spoke about that. We have to make sure the place is as good as it can be. With effort, we can do it. And we can look at the various ways to network the system so that we can get people to that place at that time. Hopefully, we are in a position where the designation will happen. Then we can start implementing, and then we will have a trauma system for Ireland. It won't be like a trauma system in other countries for all the reasons we've given before. We are different. We all know that. So I am sure there will be people who like what is decided. There are people who don't like what's decided. Once everybody works towards making sure it's as good as it can be for everybody in Ireland, I've no question that it'll work well.
Okay, thanks very much, Keith. I have a question, or sorry, a hand raised from Mr. Mosen. I have a comment in the audience that they thought we were discussing trauma teams, not the location of the major trauma centre. Fair comment. Mr. Mosen, you want to make a contribution from the audience?
Yeah, Mosen Jabatpur here from neurosurgery. So I'd just like to share some data with you from UK centres. 60% of major trauma involves head injury. Head injured patients in major trauma have 10 times the mortality rate of those without. 40% of trauma patients with head injury need their surgery within 4 hours. Neurosurgery was the specialty that's needed within 4 hours of trauma more than any other specialty. And Keith, this applies to Ireland like any other country. On the other hand, 9% of trauma patients need general surgery, 2% need cardiothoracic surgery, and 0.5% need spinal surgery. So you need to take these into account when you're trying to decide where to put the major trauma center and it is extremely important where you put a major trauma center. It will affect patients' lives. 25 of 27 major trauma centers in the UK are co-located with their major trauma center. Of the two that are not, one of them has been the subject of investigations because of near misses and poor head injury outcomes. On the, you know, you've been spending time talking about interventional radiology. Of 1,285 patients admitted to a major trauma center in the UK over 2 years, 15 required interventional radiology. 60% of them needed their head opened. If you put a major trauma center anywhere other than where your major neurosurgical department is, patients will suffer. And that is known to any major trauma surgeon or neurosurgeon across the water. You need to just look at their centers.
Thank you for that very articulate contribution. Does any member of the panel want to say anything else? Connor,
I send Fergal ahead.
Fergal, were you?
I was just going to make the observation that this isn't in our gift, whether we like it or not. That you know there was an international and national panel that was tasked with making the decision.
Okay.
The government, and I'm not sure that we could ever have another international process if it were the case that the decision made on the basis of you know an evaluation by experts was subsequently overturned. I mean, I don't disagree with Mosen's comments about the role of neurosurgery, but what it does suggest is that hot neurosurgery will need to be provided on one site and the rest of neurosurgery arguably on another. That's beyond my pay grade, but that's the way it would appear to me to going to play out.
Okay, thank you, Fergal. Connor, your hand is up, but I think that's an accident, is it?
I think it's been a very interesting evening. I am just wowed by the amount of interest and effort and collegiality that has gone into the network to ensure that there's safe transportation of critically ill patients around the country, and it has really come to the fore this week with or this recent weeks with the need to redistribute patients from our overstretched intensive cares. So Vida and your colleagues in the HSE, I think you've done an extraordinary job in coordinating all of these things, and our paramedics and the National Ambulance Service have done an extraordinary job. Can I just, for those of you who have arrived late, remind you about Charter Week next week and the really outstanding lectures. And given this evening's lecture or discussions, I think Vivian McAllister's talk about military surgery and repatriating injured Canadian soldiers from Kandahar back to Canada will be a very, very interesting lecture for all of you interested in trauma. Also, Tom Walsh has been on to me from Bahrain to say that his 31st video session will be on Wednesday evening, and that will be dealing with emergency surgery. So that session from 5 until 7 p.m. on Wednesday evening. It's a really important issue for general surgery because we're beginning to find difficulties, I think, staffing level 3 hospitals, particularly with general surgeons who have the experience and the caseload to maintain their expertise in emergency general surgery, not just trauma, because the number of laparotomies now that are done for trauma is very, very small. Can I thank Jerry particularly for bringing the group of you and the speakers together this evening, and perhaps I can leave the last word to Jerry to thank all the contributors, and thank you all for listening.
Indeed, President, thank you very much. I was going to say, can I thank the panel for actually doing all the hard work? I just pulled them together. So very much appreciated. The topic in question, this was an emergency medicine program webinar. I know there was a question about why weren't there more surgeons on the panel. It really was intended as a taster for trauma team, the challenges in the resuscitation room for the trauma team, to lead on to the IAM session on Charter Day, which I can highly recommend. Is going to be a wow about human factors in general in the resuscitation room. So thank you all very much for all your contributions.